Good morning, everyone. Thank you for joining us for this webinar today, focused on the important topic of patient flow across the NHS and healthcare system. This webinar is hosted by the National Health Executive in partnership with SAS Software, in which we'll be discussing how we can improve patient flow using data to help alleviate pressure from our National Health Service and improve patient experience. My name's Jack. I'm from the National Health Executive. Today we've got on Professor Matt Inada-Kim, consultant acute physician for the Hampshire Hospitals NHS Foundation Trust. Penny Kechagioglou, I hope I pronounced that correctly, Penny, consultant clinical oncologist and the chief clinical information officer and deputy chief medical officer at the University Hospitals Coventry and Warwickshire. And then we've also got Mark Frankish joining us, who's principal business analytics consultant at SAS Software. So just to give you a brief overview of what we'll be discussing today, our discussion will be all about patient flow and how that can be voiced across integrated care systems and where we can improve in that. So just to give you another little bit of information as well, today's discussions will be full of opportunities for not just our panelists to experience their thoughts and opinions, but for also you to ask questions and get involved. So if you can get involved by asking questions using the Ask Question icon at the bottom of your screen, that would be amazing. So if you do have any questions to put forward to our panel, please either pop their name just before your question, and we'll hopefully get around to answering them. So thank you everyone for giving us your time today. Really appreciate you being on. So Matt, I'd like to start with you if that's okay. So what are the risks from a patient safety perspective, and what might mitigate these in patient flow aspect?
Thanks, Jack, and hello everyone. So I guess from a humanistic perspective, I'm as moved as anyone to read the stories about patients having to set up, or relatives setting up, football goals as tents over patients who've fallen over on the floor and been left outside for more than a day before an ambulance comes to pick them up. It's just not the right health system I want to be working in or part of or supporting. We need to be far better and stronger than that. I don't want to be part of a system where it takes 8 minutes to pick up a 999 call or 30 minutes to come to a Cat 2 emergency. And you look at every single emergency department around the country, and there are horror stories of patients waiting 12, 24 hours, 36 hours for a bed, and in some cases for a medical assessment. And though we do our very best under extreme circumstances, it is not good enough. And the safety concerns I've got are massive and far-reaching. A recent RCAM report suggested up to 4,519 excess deaths per year from crowding and flow problems. This is not appropriate for a developed country. So the question is what we can do in the short term to improve safety within our current unsafe systems. Secondly, what we can do to provide not just the sticking plaster, but a solution in the medium term and the long term for this, recognizing that the social care funding is not coming in any speed or any solution, and that we will have to reach outside of our boundaries as a hospital system into the community and develop proper integrated care solutions if we're going to get anywhere.
For sure, I can. Okay, sorry.
No, go on.
No, for sure, that is a massive concern at the moment. I like your story of how you've seen what you started off with there, patients being on the floor. It just should not happen nowadays. So that's a really, really good point to bring up. I never realised that was the case, but that's a fantastic point to bring up. Cool. So Penny, if I can move over to you. So what have we learned from the flow challenges during the pandemic, and what innovative solutions can we deploy to improve flow in the post-pandemic phase?
Thank you. Great to be here today. I really agree with Matthew's comments, and we've seen the risk increasing in patients waiting longer for an ambulance, but also waiting on the back of the ambulance also when they reach their the A&E and the place where they need to go and be seen. We also see that. And so it's important that we address flow in the organization in terms of how do we manage patients on the ward, discharging, and the flow into social care, as Matthew mentioned. So there are lots of opportunities, and we saw during the pandemic how we've managed to triage and streamline patients coming to accident and emergency, like creating direct access pathways in new units. So we prevent people stacking up on corridors, for example. So we used innovative ways and pathways to enable surgical patients, for example, to go straight into a surgical unit and be assessed, or patients with a medical problem go straight to a medical assessment unit. Same with patients with gynecological problems. And we work really closely with mental health units so that we can manage patients coming into A&E with mental health problems. So we need to learn, and we need to capitalize on what we've learned during the pandemic. And digital technology, we know, is one of the biggest enablers to be able to keep the patients in the community and closer to home, and reduce demand for acute healthcare, especially in the population where we know they suffer from long-term conditions. And inevitably, those conditions will flare up. And what happens is patients with COPD or with heart failure, they end up in A&E with the whole traumatic journey. How can we proactively follow them up in the community and prevent deterioration? And we can do that now with digital technology. We've used remote monitoring systems, and during the pandemic that we are now scaling up, and those have proven really beneficial for patients living in care homes, but also enabling our people with chronic health conditions be treated at home. So there's a lot of opportunities there.
For sure, and especially moving on to this digital age that we now find ourselves in, that can be fantastic for the future as well. Definitely bringing back to Matt's point, as he said earlier, getting people through that healthcare system will be critical going forward. So moving over to you, Mark. So one of your questions was, how can analytics, data and information help this patient flow problem, and how can it help triage in and ensure those who need care the most get it first?
Yeah, thanks, Jack, and good morning to everyone on this session. So interestingly, I come from a data science background, so I don't have a health, or I'm not a clinician. So the way, and I work for an analytical or machine learning company. So the way we approach these problems or issues is firstly from the data point of view. And what we try and do initially is understand and model the existing patient flow or care systems. So for example, if we're looking at a trust, we can understand the episodes and the typical care pathways of different types of treatments. And once we do this, we can then start to look at avoidable harm or avoidable conditions that may occur with a typical treatment path. And what this will do is give insight or early warnings or triggers to say, right, you've got this group of patients and they look like this from a clinical perspective. From our experience in looking at the historic data, these are the most at risk of perhaps, let's say, developing septicemia or pneumonia or something like that. And that early warning system will be able to help you triage or be more preventative in the treatment that you're delivering, rather than letting the unavoidable harm or episodes to happen. And we can do this across, we can do this within care systems, but it's even more powerful if we can do it across the whole integrated care system and looking at different points of care. So what's available in the community, mental health, GP, and as well as trust. And what we've seen is that if we start to include the data across a more integrated care system, we can start to impact sort of bed blocking. Because a lot of times patients we see are, they are ready to be discharged but aren't, because something in the care community or in the social care side of things isn't in place. So they're not discharged, they block the bed. And with being able to profile and model the care pathway, again, we can give early warnings that say, by the way, these patients which should be discharged in the next day, they are going to need crutches or a wheelchair or something available to them in the community before they can do that. So let's look at setting that up and getting that in place so that we can reduce the bed blocking numbers.
For sure. Penny, I could see you nodding your head there. Have you got anything to add to that one?
All those points, Mark, are fantastic points. I think the importance, as you say, is to understand the data, to understand what's happening and the outcomes of the care that we deliver. And that's the first point of understanding what works and what doesn't, and what care we need to put for which specific cohort of patients. Also, the predictive models that you talk about, by having robust data sets, only then we can actually use effectively those predictive models. And I currently work on an electronic patient record implementation project. And again, that has to happen across the ICS, as we are doing at the moment, implementing a single EPR, which is the first step in bringing that data together and start to understand those pathways and the outcomes of our patients. And then we will be able to predict and form all those smart analytics you mentioned. So it's really an exciting way forward.
Brilliant. Matt, do you have anything to say for that one as well? Because I think that's quite a really intriguing topic.
No, digital interoperable systems are the key going forward. But I would rather have slower progress on developing those systems to ensure that we have properly ergonomic systems that are actually usable for clinical colleagues around the organizations. Because the dangers of moving too quick and too fast on a digital system is that we break the system and have a not fit for purpose EPR. And I've seen it so many times, and it disengages the clinical workforce from IT projects, or indeed the ideas and flow and enthusiasm for them. And that is so important when we are looking at long-term, large-scale change. 50% of any investment needs to be about the usability of the system, not for the bells and whistles that are going to win awards. It's about how they are usable for the people that need to use them. The quality of data out is completely dependent on the quality of data in.
For sure, and bringing everyone, again, it's that bringing people forward and bringing that workforce to work so efficiently. That is so key at the moment, especially post-pandemic as well. Penny, I'll ask you another question if that's okay. So if you can tell me about some of the local successes improving flow related on not to use the use of digital technology, if you can expand on that a little bit, that would be amazing.
Sure. I've got plenty of examples, but I will focus on the subject of remote patient monitoring, which I alluded before. And we used a digital platform for patients who live in care homes during the pandemic. And we currently have 100 patients in care homes with monitored through virtual wards. And we also have hundreds of other patients with long-term conditions now being monitored through virtual wards, including patients with respiratory conditions and patients with heart failure, for example. And that has shown very positive effects in terms of preventing deterioration of those patients and preventing acute admissions. But we need those data outcomes, as Mark says, to understand also from a patient perspective and a patient experience perspective and quality of life, what does that mean for them? We know that potentially the cost will reduce as well as being efficient and as well as improving patient outcomes. So all those outcomes need to be measured and evaluated. And those innovations will spread if we know that they work and we evaluate them properly. So I would say the biggest win for us has been the virtual ward project, which we are currently expanding across the ICS.
Brilliant. Mark, do you have anything to add to that one? I know your recent answer was very similar to that as well. So
yeah, and that's been my experience. Is typically in the more old and frail that are getting care at home or in care homes, they may need their blood pressure checked, or they may need wound or pressure bandages changed. And how we typically, I always say that the NHS is a sickness system, not a wellness system, right? You get sick and then you get treated, and there's not much preventative stuff. And it's difficult to measure the preventative stuff, because if you stop bad things happening, then they never happen, so they're never recorded or costed, right? So, for example, there was a practice where, in care homes, whatever treatment the residents needed, they would all sort of get bused or taxied to the local GP or the hospital to receive their treatment and then taken back. Now, that they didn't enjoy that experience. They were uncomfortable leaving their homes or leaving their care homes. And we proposed a very simple change, which was, can't a community doctor go into the care home on one day a week, let's say a Thursday, and everything that needs to be done, the patients in there can just go to that, and running that and looking at the patient outcomes. That was a much better service. They could stay in their homes. They knew the doctor was coming on a particular day. They could have longer appointments and chat, and there was a cost saving to that as well. And I think also on the preventative side, we did some work on people that have arthritis. A particular drug makes them a bit wobbly or a bit shaky, and they are then more prone to falls. Okay, so what I'm saying with the preventative stuff is, if we know in the care system that we are prescribing these particular drugs and they have these effects, let's do preventative measures, whether it's an email or a telephone call or whatever it is, to say, look, we've got this service that can help you. We can send you a car, or we can take you to a community center. And those things could then potentially prevent these patients falling and doing more harm to themselves, which will then result in them actually having to go to inpatients and incur additional costs. So I think, yes, if we can understand all of these triggers across the care system and do more of a preventative approach, then that will be better. As I say, it's difficult to measure, but also we've lifted this. I think it's an interesting dynamic for the UK population, because this is not something we try. We don't necessarily contact patients and say, look, from your last records, it seems you're gaining weight, etc., etc. You might be at risk of type 2 diabetes. But if we look at the models like in the States, where it's a premium and it's an insurance model, they're very used to doing this, contacting their customers, if you like, and saying, we think you're going to develop one thing or the other. And they get the patients to interact, because the threat, if you like, is we'll either increase your premiums, or we will not insure you, or we won't insure you for this particular area. Now, that's not available in the UK, because it's obviously free at the point of delivery. But I think we need to adopt that sort of model, because it gives more responsibility to patients for their own care, and also choosing what type of care they get.
No, for sure. That's a really good point. And you also brought up virtual wards, which we, like both you and Penny brought up virtual wards, which is, in my opinion, one of the biggest game changers to come out of the pandemic. I know, Matt, we had a conversation a few months ago about virtual wards and digital care and how that can help those people go forward. Have you got anything for that from Mark?
Yeah, so I mean, I think what we fundamentally require is a transformation of community and integrated care. Essentially, we need a diminishing, essentially, of what happens in secondary care and primary care, and a bolstering of what happens at the interfaces within integrated care from a clinical model perspective, and also the digital systems that support them. What we need is time and capacity to address that population of sick patients who are at the highest risk of deterioration or coming a cropper. And we know who they are. Everyone knows who they are, but we may have different IT systems and EPRs that will identify them against strict criteria. So the question is how you free up capacity across the whole of the healthcare system to enable a focus on preventative care and chronic disease management. And the only way we're going to do that is by altering the entire model of healthcare delivery. So fundamentally, what we need to think about is how we deal with acute episodic care and how we deal with chronic and preventative care. If we can get an honest conversation going about what transformation is required, where funding shifts need to happen, where personnel changes are required, and what collaboration needs to happen between organizations, then we have a chance of surviving as a healthcare system. If we remain siloed and don't look above our parapets, it doesn't matter what IT system gets put in place, it won't succeed. So what we need are conversations, and we need collaboration if we're going to get anywhere in this process.
Staying silent doesn't get us anywhere at all. So definitely having those conversations really will help. So Matt and Penny, just one for you guys that will be really good, I think, to answer. So what do you think that the next? What is the next thing that you would like to see implemented within your specific NHS trust that would positively impact patient flow? Penny, if you'd like to answer that one first. I know it's a bit of a curveball.
So I think joining Mark's and Matt's responses is the answer. I think Mark is describing the system of the future, which is where we should be aspiring to be, really, and have that data and understanding and be able to proactively go and talk to the patients and manage lifestyle change, risk, and prevent getting them into a long-term illness point. And I think Matthew is more practical now. What can we do now? Where can we start? And the truth is that, as Matthew said, we need to start slow but aiming big. And we need to target the people who are more vulnerable, who we know, for example, that they come to A&E 3 or 4 times a month for a specific issue. They may come from vulnerable communities. So we need to be mindful that not all patients have access to digital means, and we cannot exclude the people who may not be able to come to their clinic appointments because they don't have transport, or they may not be able to access care, and they end up in acute care. So for me, the priority is understand our populations, understand who is seeking care more often, and trying to put measures in place through community care, through social care, to cover these population needs. And then building up on that, moving to the next layer of patients who are on long-term care, expand our technology, our remote technology, to patients on long-term care. And thirdly is, how do we address the whole population in terms of lifestyle changes? We've seen health coaches coming now and working in primary care. We've seen social prescribers coming into the system. How can we utilize those professionals alongside the clinicians to be able to deliver care closer to home?
Fantastic. Matt, I think you touched very quickly on that subject as well. Would you have anything more to expand on Penny's ideas?
Yeah, I guess so. I work in acute emergency work clinically. But I guess my national role is more systemic and strategic. What I would like to see my organisation doing is reaching out and developing integrated assessment strategies, coordination of care hubs within the community, essentially, to fulfill the need as a single point of access, to ensure that patients have access to same-day urgent care appointments in the community, supported by a combination of primary care, community care, and hospital specialists. So they do not require a hospital to get the outcomes they need or the tests they need, or to get an opinion or an assessment and management. They can have it all in their own homes. And then to enable that, as I've said before, we need a transformation of care. Hospitals have to support the community if we're going to get anywhere, and hospitals will benefit from doing so. This is a whole population solution, something that ICSs and ICBs were formed to do. They are going to be the beneficiaries along with patients, and they need to take a lead on this. They need to support it, they need to fund it, and they need to I think, strong arm local organisations into playing ball. Because at the end of the day, the people we answer to are our population. And if our patients can't get access to healthcare in the community, we've failed as a system from an emergency, an elective, and a non-elective perspective. It has to be our number one priority. The only way it's going to be achieved is by essentially us breaking down the model and actually looking at where we need to fill the gaps and how we need to collaborate in order to achieve that. So it's a wide-ranging answer, I'm afraid, but at the end of the day, it's not going to be a sticking plaster if we're really going to have a fit-for-purpose healthcare system for the next 5 to 10 years.
For sure, it's more of a long game than a short game, for sure. Mark, if I can come to you. So after NHS England announced that every ICS should set up system control centres at pace, so how quickly do you think some of these digital solutions can be implemented across the ICSs?
Yeah, that's a $100,000 question, I guess.
Sorry.
Yeah, I mean, ICSs are bringing different care organisation or service providers together, right? So trusts and GPs and community care and mental health, these organisations have typically worked in silos, okay? Or they've worked, and I mean from a data point of view, they've worked in silos, and the data is not shared. So the greatest challenge for the integrated care systems is to provide a platform that can bring all of this data together in a patient-centric way, right? So not just bring it together and kind of squash it together with no patient at the center or the focus of that. So that's a challenge because there's different data systems, but the technology exists. This is not a technology issue. The technology exists to be able to do this, to develop platforms. With the emergence of cloud or more prevalent cloud technologies, it's more easier to start to bring and integrate this data together. But it's not just an integration problem either. It is an analytics problem because the data needs to be joined at a patient-centric level. And I know we've started to do this in NHS England around the national NCDR, the National Commissioning Data Repository, which is looking at commissioning services for patients. So it's slightly different. But the focus for the integrated care systems will be patient-centric. And then both Matthew and Penny started to use the words population health, which this is exactly what this is. Okay, it's understanding the population from a health point of view, but I would even suggest that we go further than that. So not just health data, but start to try and introduce socio-political data and to what Penny mentioned, I think, around the more vulnerable and the more deprived areas. This sort of lends itself to this new program from the NHS, I think it's called 20+5, if people have heard of that, which is starting to look at developing population health to target the more deprived and vulnerable areas and see what sort of care can be provided with them. So yes, there is a technology element where we need to bring this data together. We need to shape it in a patient-centric way. We need to perform the analytics on that, because once data is brought, you get hindsight, right? You can see what has happened, but applying analytics gives you foresight. So it allows you to apply what if we do this, or what if we change that, or what if we simulate this in some different way? Do we get better outcomes? Do we get better patient satisfaction? So it's there. We can do it. It's not going to be easy, and it's not going to happen tomorrow, but it's what the goal should be and what we should.
That momentous challenge to do to bring those systems into fruition. So I'm actually going to move on to some of the questions we've got in from our audience. I'm going to start with Jane's question. So Matt, would you consider offering to be a special advisor to the Health and Care Secretary to keep them aware of the true danger and catastrophic care some receive?
I mean, it's an interesting question. I think it would be great if they listened more to clinicians. I'm not sure I'm the right person for that role, but absolutely, we need proper clinicians representing us at the top table.
No,
in the Netherlands, they don't have a political secretary of state. They have a doctor. And I'm not saying it has to be a doctor, but my point being, let's get someone who knows what they're talking about in charge.
For sure.
Quite honestly. Or at least reaching out to proper frontline people who do it, and patients who live it, and carers who suffer within the healthcare system, and people that work in social care who, quite honestly, are the biggest heroes of all on the limited amount of funding they receive. So we have a truly representative, powerful voice at the side of whichever political party is flavour of the month. So in answer, we need someone probably better than me, but someone who's probably going to be as vocal as possible and not pull the usual rhetoric and listen to the party line, quite honestly.
For sure. No, definitely. So just to bring on to Stephen's question as well, I think this one's open to the floor. So your initial comments highlighted the pressure on the ambulance service. With him being a district councillor, he's the first responder within the ambulance service. So in his dearest experience, and anecdotally a key area of pressure, the transfer of patients from 111 and difficulty in accessing primary care. This amounts to some 30-40% of calls, most of whom are not transported but dealt with on a see and treat basis, often referring them back to the primary care system. So the question is, can modelling of the chain of care include primary care as well? That one's open to the floor. Whoever would like to answer that one?
I'm happy to, if you're not tired of listening to me, absolutely.
Not at all. Not at all.
We're on the same page. So we did a recce at my ED looking at people that could have been dealt with in the community. And I'm not having a go at general practice because they're completely overwhelmed. It's not their fault. But up to 45% of the patients we audited on a single day could and should have been seen perhaps in the community if the services had been available. And just by doing that, that's real low-hanging fruit in terms of, if we can turn off the tap in terms of those avoidable attendances, suddenly that 8-minute 999 call, or the 30-minute wait for a Cat 2 ambulance, or the 16-hour wait to be seen in the emergency department disappears because we've got a department that has a bit more flow to it. We're not very efficient and effective at saying no, turning off the tap and saying that's not appropriate. It's not very political, isn't it, sometimes to do so? But we need to be a bit braver about doing that and ensure we have clarity on what sort of patient we want seen in which part of the system. And only by doing that and having that honest conversation can we, I think through proper public health messaging, that we can then influence the behaviour of our patients and develop the systems that we need that are fit for purpose. I'll cite you an example from acute respiratory infection. So this is my field, but from an ARI perspective, acute respiratory, so that's including COVID, flu, RSV, bronchiolitis, upper respiratory tract, lower respiratory tract pneumonia, which is our big worry this winter. We estimate about 50% of NHS bed occupancy is going to be full of it. We need to improve the way we have the right patient within the emergency department. Currently, out of the 1.13 million attendees in EDs across the country per year with acute respiratory infections, only 25% get admitted. 75% of patients could potentially have been seen elsewhere. I'm not blaming anyone, but there is a gap in the market. And the gap is the provision of same-day urgent care for a whole raft of acute conditions, a hell of a lot of them infective, a hell of a lot of them addressing frail elderly patients. If we can get that part right, and the same day access, and a simple system that has a single point of access so that patients know where to go, as opposed to a myriad of different confusing options in a timely manner, then I think will be a real win for this winter.
No, brilliant. I love you. I love your passion behind that. That answer. I think that's fantastic, and that's what we really need, is those passionate individuals to go forward, and deliver on that topic. Penny, did you have something to say on Stephen's question?
Yeah, absolutely. Great question. And I fully agree with Matthew. We've done similar audit in our organization, and up to 40% of patients coming into A&E did not need to be there. They could be served better by a same-day emergency care, a same-day urgent care. And again, it's not blaming anybody for this, it's understanding and creating those pathways. And only by doing so, and the clinical leadership behind it, it's very important that we use clinicians to design those pathways who understand the problem. Matthew said that really clearly. And only by doing so, we can then educate our patients how to use those pathways and how to use access to care more appropriately. Because we all know that if patients get trouble getting through a service in the community, by default they will come to accident and emergency because they want the problem sorted. So we need to work harder to achieve the long-term goal at the end of the day, which is improving health and care and improving experience for our patients.
No, fantastic. Mark, do you have anything to add to Stephen's question as well? Or?
Yeah, I don't have much experience. I do have some. We have looked at the ambulance service specifically, and again, coming at it from a technology point of view, you know, what we were looking to develop is there's all of these risk stratification models out there that are freely available and published, and they determine the risk of heart attack, the risk of stroke, or whatever it is. We were looking to implement these in a mobile way. So smart devices are everywhere now. So to better triage the ambulance call and where that person is routed is having these risk stratification models on a device, so that you can put in, which is usually very straightforward and simple information, which the medics would gather to say, actually, this person's, you know, most likely is actually having a stroke, so they need to go to a specialist stroke unit or whatever, or this person is having a heart attack, or actually this is routine, dare I say that sort of word, I don't know the correct medical words, but it would be very quick and useful to have for the ambulances, so that they can triage and know perhaps where is the best place to take these patients, and that will hopefully alleviate in some way the wait times, because they're not treating everybody the same. They're getting some informed information of perhaps where they should route or take those patients for care.
Fantastic. No, really, really insightful stuff there, guys. Thank you for answering that question. I've got a question from Fiona Cooley, and I think, Mark, you'd be really good to answer this one first, and then obviously Matt and Penny, if you can join in as well. So how much will the proposed ideas rely on patient use of IT? In many places, the most vulnerable, needy patients are invariably very elderly and are totally unable to access or even understand any online requirements. Yeah.
Yeah, and technology should be an enabler, not an inhibitor, right? You shouldn't be able to not access it because you don't have either the devices or the knowledge. And what we try and do when we deliver our analytics is make it make it a result, if you like. So it's, if I take a step back and explain. So let's say we develop a risk model. This patient is at risk of developing type 2 diabetes. there's no point stopping there. You need to then explain why. So why are we saying? Because they have these attributes, okay? And then again, it's not stopping there. It's then coming up with a recommendation, if you like. So the recommendation is the really important bit, not how to use technology or the fact that this has come from a risk model. It's that a machine learning algorithm has told us this person's at risk of type 2 diabetes. This is why we think they are at risk of type 2 diabetes. And this is what we think you should do in terms of an intervention plan. Now, that intervention plan is what needs to be communicated to that patient, not we've run a risk model and this is what the computer told me. And so that intervention plan can be delivered by a clinician. It can be delivered by email or whatever target thing is best placed for that patient. So if they are old and frail and not familiar with technology, then that should be presented by a district nurse or their GP or something like that. But with somebody like me who's got more sort of tech savvy, then I might just want an email or something like that. But that delivery, that recommendation is what is important, and that should be determined by how best that patient should receive that information.
For sure. Matt, Penny, how would you respond to?
I'll go next if that's okay.
Yeah,
I mean,
of course.
I think that any technology that we use and patients use as end users should be very simple, and it should be accessible, and should be affordable. Okay, for me, these are the three requirements. I agree with Mark that for people who they have no capability or knowledge to use, we can use professionals in healthcare, district nurses or local pharmacists and local, there are now care hubs in high streets where patients can go and seek support. Every opportunity to train and teach patients how to use technology, which is simple, accessible, and affordable. I will also say that it's important to realize that patients live with carers or family members, and for some of them, it may be appropriate to get support from a carer to access and enable them to use that technology to be able to record all those metrics, diabetes, etc. So we should see the patient as part of their own network as well, which can be very helpful in those circumstances.
Fantastic, Matt. I saw your head going quite a lot there with Penny.
I think both of them have answered the question very comprehensively. And I guess one of the fears I've got about tech, and I'm sure everyone else agrees, is around the exclusivity sometimes of the systems, and sometimes we can worsen the inequalities simply by developing an incredible digital system that not everyone's able to use. So I love your comments, Penny, about simplicity, because that's absolutely right. We've got to make this an equalizer, if anything. In terms of successful projects I've seen, I think some of the key elements from the COVID monitoring elements that really worked was the use of smartphones. So patients were texted, what are your oxygen levels, how are you feeling, how's your cough, how's your breathing, on a daily basis. I think it was 3 times a day, actually, in terms of monitoring. They were asked to then input their data, and it came up on a dashboard that surveying clinicians could look at, and mean that instead of a clinician phoning every single patient on a list, and there were up to 200 or 300 patients at any one time being looked after on these COVID wards, they only had to contact the ones that were flagging up on a RAG dashboard that had amber or red symptoms or observations. So it's an incredibly useful labour-saving device that empowered patients, so they were able to articulate when they were not feeling well, and they were able to escalate when their oxygen levels were dipping, but was utilised by the healthcare to properly triage urgency and severity to ensure that it improved the efficiency of the healthcare system as well as the quality of care delivered. So whatever we come up with from a digital system, it has to, as people have said, has to be simple, has to equalise, but it also has to be really impactful and useful. And then if we are to get to what Mark said, get to a point where we have this data at scale, we can then suddenly realise using apps and big data, what the real significant symptoms of concern are. Something that, not even organizations like NICE have really looked at, because it's too grey an area. Do we really know what people say in the immediate 24 hours before they die, or a week before they die? What is actually the whole basis of healthcare? Because at the moment we have a very disease-driven approach to healthcare. As Mark said earlier, we have labels and diagnoses that we use as clinicians and healthcare systems that don't actually fit with how patients present. And this is our opportunity, is to use tech to get to what real people say when they become ill, and then use that big data to determine urgency and triage at the call handler phase and at the single point of access or at a hospital front.
No, fantastic answer there. But thank you, guys. That was really, really insightful. I've just got a question from Hugo. He's directed this one to Penny and Matt. So what solutions should be implemented at the boundary between in-hospital and out-of-hospital care to improve the discharge of pathways 1 to 3? Patients given bed blockage of patients without criteria to reside is a significant challenge. So what do you think to Hugo's question? Do you want it, Matt? Penny? Yes, yeah, sure. Go for it.
I think, first of all, it's very important that we clarify criteria to reside clinically, and those are agreed by our clinical leaders. I think that's the key. And when I talk about clinical leaders, I don't just mean the secondary care, I mean across the whole ICS. So the first step for me is agreement of what that means, and also including, patient representatives in that conversation, and, be brave enough to actually understand and explain to the patient experience forums that this is necessary in order to sustain our healthcare system. So patients that actually need the bed, get the bed, and patients who can be managed in the community are better managed there. So those are conversations to be held. In terms of technology, again, I go back to my original answer about remote patient monitoring, and there are different technologies out there. So I wouldn't exclude or point to a particular one, but simplicity is again key, and picking up a technology that's actually standardized across the system. So the last thing we want is to have patients using different portals and different apps according to what organization they end up within the system. We need to agree amongst us on a standardized solution and a standardized platforms, so that patients have a single point of access. If they want to see results, if they want to look at their appointments, change their appointments, manage their own bookings, and look at the discharge summary and everything, we need to enable patients to have that simple access. And I think what we are doing sometimes is we overcomplicating things, and we end up with 3 or 4 different apps, which becomes unmanageable for patients, and then we are risking losing the adoption from our end users. So in summary, I think a standardized solution, a platform that patients can easily access, and that bi-directional communication with the clinical team within the remote patient monitoring program is key.
No, fantastic. Well, I can see you're in such agreement with Penny. Do you have anything to add on top of that?
Really good answer.
Yeah.
I think short of paying social care what it deserves and needs, I think what Penny touches on are the right answers. We need clarity. I would love to see a digital tool that actually gave us a prediction of relative harms of being in a hospital bed compared to being at home, because I haven't seen that anywhere. And as a clinician, as a patient, as a relative, that's the sort of info I want to know across the system. Am I actually putting this patient more at risk by keeping them in a bed without the complete social care package they require, compared to actually sending them home with a little bit of risk? Because I'll tell you, that isn't the risk in the system. The risk in the system is exactly what I said at the beginning, is waiting 8 minutes for a 999 call, or being at home on the floor, having not been assessed. That's where our biggest risk is. And yet we focus all our minds on the litigation, the potential suability of sending a patient home early who's medically fit for discharge. I'm not blaming the patients. It's not the patient's fault. It's not the clinician's fault. It's not the healthcare managers who work night and day tirelessly to try and improve the system. There's a fundamental issue with where risk management sits and support for taking those risk management decisions on discharge. And then, as Penny says, coupled with IT systems that are fit for purpose in terms of pulling together risk calculation and a tipping point, which we get to, where it's actually more risky to keep a medically fit patient for discharge in a hospital bed for a prolonged period of time. It's not what patients want, but it's what our system has artificially created, and that extra pressure is breaking us.
No, for sure. Sorry, I'm just really aware of time now. I think we've got about 8 minutes to go. So I'll come to the questions just one more time, and then I think we'd have to wrap up after that. So I've got another one from Jane, actually, Mark. So data is king, as you say. We have proven that we're having people with BME wait longer. We need to try systems out on different groups to make sure it's logical, makes sense to them, and as you say, improves the outcome for them. So do you have any opinions on Jane's kind of statement?
Yeah, I think this lends to the ethical nature of analytics or AI or machine learning, whatever you want to call it, which is becoming more and more prevalent in the industry in terms of being, ethical, transparent, and responsible. It's an interesting one, and I'll just do an anecdotal story because it kind of highlights the parody here. I don't know if people remember, there used to be adverts on TV called Sheila Wheels, which was an insurance company that gave preferential insurance to women drivers. Now, what the advert was suggesting that was women drivers were better than men, so they would get a preferential insurance. What the analytical model actually found was that women have fewer accidents, and when they do have an accident, it's of a lower cost. So that was what the model was actually saying. And so this insurance company went, well, if we give women drivers preferential insurance, it's better for us, more profitable for us. The European court ruled that this was discriminatory against men, which brings in this ethical element that we shouldn't introduce bias into our models, consciously or even subconsciously. But it's an interesting one in health, I think, because there are gender and ethnic considerations, because like we saw with COVID, the BME community were more vulnerable. And so I think it's just an ethical debate, okay, where we need to have ethical and transparent AI on the data, but also be conscious that sometimes that element is actually important. So that was my best way of not answering the question, but just proposing this is an area that needs to be thought about.
Brilliant. Okay. Fantastic. I know we've got just under 5 minutes left. Do you guys have any final thoughts on how we really can transform patient flow across integrated care systems, and just where your visions are for the future? If Matt, if you'd like to start us off with just your final thoughts on the topic.
I mean, sorry, at the risk of repeating myself, but I think it's all about collaboration between the different interfaces of care and proper respect for cross-silo understanding. Because if we start from a position of respect and understanding that everyone is actually doing their level best to keep us going as a system, I think we're 30% of the way there. But it's fixing the headspace time in which to actually properly collaborate to develop these solutions. That's the real challenge. Because everyone's 150% in their day jobs. So how can we free up 5% to actually think about the what if we did something different? How do we do something different to actually improve everyone's working lives, and most importantly, the access and quality of care we deliver for our patients?
For sure. Penny?
Thank you. For me, true integration is stop working in silos and also learn from each other. I mean, there are 42 ICSs, okay, and I bet we are doing different things in different areas. How can we learn from each other? How can we learn and adopt solutions that worked somewhere else, and scale up those solutions, and stop making things complex? You know, we know what the problem is. We need to systematically work together to address this, and we need to bring our services together. It's not about primary versus secondary care. It's about the system and with the patient at the center.
Fantastic. And obviously it's always about the patient care behind it, and how we can deliver best for our patients in the NHS. Mark, any final thoughts from yourself as well?
No, I mean, I would 100% agree with that, and just say from a technology point of view, it should be an enabler and a supporter. I see a lot of press, around AI going. They make it a competition, and they go, AI is 4 times better at detecting cancer than a clinician, and it's not a competition. AI is not there to compete with clinicians. It's to enable and support them and help them to make a better decision. So it's kind of a pet peeve of me to see when other organizations make a competition. It's an enabler and a supporter of the person-generated care provider.
Definitely, for sure. Well, I think that's all we've got time for. I know. I just really want to thank everyone for speaking today, and just agreeing to come onto this webinar. I found all of your comments really, really insightful, and it seems like our audience has as well. We've had absolutely loads of questions. I'm really, really sorry that I haven't managed to get through all of them. But if you do have any questions that you'd like to put forward to us, if you can email us at marketing@publishing.com. I'll write the email in the live chat after we come off here. Again, thank you so much for everyone who has taken the time to join this panel discussion, and thank you to everyone who sent in those questions. And also thank you to our event partner, SAS Software, who without their support, this event wouldn't be able to take place. So from me and everyone at NHE 365, thank you so much for listening, and I look forward to seeing you at our next event. Brilliant. Bye for now.
Thank you.
Bye.